Well, good afternoon, everyone. Thanks for joining us. This morning, Humana released our 2020 Vocal Progress Report at populationhealth.humana.com. It includes highlights from our work in population health, and in particular, our work with the social determinants of health. In conjunction with this report, we have hosted a series of virtual population health events at the National Press Club. On Tuesday, Caroline Coates moderated a discussion on the addressing social determinants of health in seniors. On Wednesday, Trey Cockrell led a discussion on reshaping clinical education as a result of the COVID pandemic. And today's topic is, it's time to address racial inequity in population health. We're at a pivotal moment in our country's history, and the conversations we have now, actions that we take will shape our path forward. We all have biases resulting from our life experiences. To get beyond them, we need to have difficult conversations. We need to listen and learn from different opinions. And we need to make positive change. The long history of racism and discrimination in our country has reached a breaking point, and many people are rightly upset, frustrated by the lack of progress. This has been magnified by the additional hardships that come about from the COVID pandemic. So let's have this conversation. I'd like to introduce our outstanding panelists. First, we have Dr. Patrice Harris, psychiatrist, a fellow of the Psychiatric Association, 174th president of the American Medical Association. Dr. Harris has diverse experience as a private practice physician, public health administrator, patient advocate, and medical society lobbyist. Dr. Schrank is our next person. He's Humana's Chief Medical and Corporate Affairs Officer. He previously held positions, senior positions at the University of Pittsburgh Medical Center, at CVS Health, and the Centers for Medicaid and Medicare Services. Our third panelist is Dr. Brandy Pryor. She is Humana Foundation's Senior Director of Programs. Before joining the foundation, Dr. Kelly Pryor was the inaugural professor and director of the Center for Health Equity, which is a division of the Jefferson County Department of Public Health and Wellness. And our fourth panelist is Shantanu Agarwal, President and Chief Executive Officer of the National Quality Forum. He's a board-certified emergency medicine physician. He has worked in both academic and community settings. He's also the former Deputy Administrator for the Centers for Medicare and Medicaid Services and the Director for the Center for Program Integrity. So, four very impressive panelists. And I'd like to start just by asking each of you to make some opening comments, your thoughts about racial inequity in population, just your perspective from your organization. So, Dr. Agarwal, would you like to start?
Thank you, Andrew, and I want to thank Humana for the invitation to come present with you all. It's really a pleasure to be here, and I certainly think about this discussion in the context of everything that's been happening externally around protests for racial justice and the BLM movement. At NQF, we have tried to play our role in furthering this dialogue over the last several years, trying to play a leadership role, but also, I think, importantly, in our organization, playing the important role of convening a diversity of voices that can help lend to and drive a set of solutions. I think where a lot of our work has stemmed from recently is from a disparities roadmap that we published now about 2 years ago, that I think did a couple of important things. So first, it really tried to connect addressing disparities to the broader issue of health equity and working to achieve health equity, which I think we recognize as a much bigger topic in this area. And certainly the words matter, and I know we're going to discuss that further later today. The second I think an accomplishment of this roadmap is to really work towards identifying the most salient issues and working to identify interventions that have been demonstrated to work. We have really tried to base the then subsequent projects and work that we've engaged in off of that roadmap. Last year, we convened a payment summit specifically on addressing the social determinants of health. We've started to think through social risk and how that intersects with measures, and even work to catalyze the creation of new measures and intervention approaches, for example, focusing on food insecurity. So again, that's just a nutshell. I think there's a real opportunity in the panel today and just overall in translating the important national dialogue and really thinking about the impact on healthcare. So I look forward to that discussion today.
Fantastic. Thank you. Dr. Harris, would you like to go next?
Absolutely. Well, let me thank Humana as well for putting together this panel. It is absolutely time that we are having these discussions. Of course, I know this panel today, but many on this panel have already been looking at these issues because COVID-19, the current pandemic, has brought into stark many issues. Two of them, of course, are health inequities, and of course, the other is mental health. And so I would have to say that any conversation, debate, discussion we have about health that doesn't include equity, that's today and that's going forward, or mental health is certainly incomplete. And any solutions that don't address the broader causes of health inequities is certainly incomplete. And of course, those include structural causes. We have been talking a lot about the social determinants of health, access to housing, equitable educational opportunities, transportation, food security, but we also need to even look further upstream at those structural determinants of health. Of course, we are now talking a lot about racism, structural racism, and interpersonal racism, and those unconscious biases. So we need to continue to have those conversations, and though they may be difficult, we must begin to have those conversations. There also has to be a commitment to educating. If you are not aware or uneducated about really 400 years of injustice and how that has contributed to where we are today. At the AMA, we are doing many things. I'll just highlight three to begin, and we can discuss further later. But a couple of years ago, we established our Center for Health Equity at the American Medical Association. We hired our first Chief Health Equity Officer, Dr. Aletha Maybank, and we will be partnering and convening and leading on the discussions around health inequity and all of the root causes. Just last month, we launched a partnership with Essence, as well as the American Heart Association, the National Medical Association, and other groups to really target Black women and make sure that Black women are aware of their own risk for heart disease. And our campaign is aptly titled Release the Pressure. That's such a good campaign name, in my opinion, on so many levels. But we want Black women to know what their numbers are when it comes to their blood pressure. We want them to partner with their physician on a plan to address any issues around heart disease. And we always say, connect with your squad, right? Do wellness checks, because that is a very important part of heart disease and really an overall health plan. And finally, we are modeling and piloting a program in Chicago. The AMA is, of course, a national organization, but we believe that organizations with resources should commit those resources to perhaps small pilot projects that can then be scaled if they are successful. And we are working with several others on the west side of Chicago. Certainly, we know that communities need to tell us what they need, because trust is a significant issue, particularly in the Black community. So those are just three of the things that we are working on at the AMA and many more. And again, so happy to be a part of this conversation.
Thanks very much. I look forward to getting into all three of those topics deeper in a few minutes. Dr. Schrenk, would you like to go next? Dr. Schrenk, we can't hear you.
Thanks. Sorry, can you hear me now? Great. Well, I agree wholeheartedly with the comments of Dr. Harris and Agarwal, and are really grateful for your participation. You're joining us today. You're both real leaders in this space, and it's great to have your perspectives and your thoughts. At Humana, we've had a long-standing commitment to trying to address some of those key drivers of disparities that we've witnessed for decades in the U.S. in the delivery of healthcare and the health outcomes that we produce. And many of you are aware of our profound commitment to addressing social determinants. And the bold goal, which was announced a little over approximately 5 years ago, with the goal of getting really deep into communities, understanding the fabric of communities, partnering with community-based organizations, with local governments, with providers, with key partners in communities to understand how to address a whole array of challenges, very personal challenges that our members experience in achieving their best health, that many of which are driven by their social context. I think that commitment is longstanding and has been quite profound, and I think the evidence that we published today in our Bold Goal Progress Report really demonstrates that over time we've been able to make a difference, and this year have considerable improvements of healthy days, patient-reported health in every one of our Bold Goal communities. The events of the last month have really highlighted the fact that this can't be an implicit process. We can't just sort of focus on social determinants and believe that we're addressing the holistic nature of the problem that we're seeing in society today. It needs to be explicit. We need to be explicit about measuring health disparities and assessing sort of the structural racism that's impacting the lives and the pursuit of health and happiness in our membership and our fellow Americans. And I think it's really forced us all to kind of look in the mirror and figure out how can we do better. I think for us, one of the places that we're gonna double down, triple down, is in our hometown of Louisville, where Breonna Taylor was murdered, where there is, there are incredible disparities depending on where you live and the color of your skin. And we know that we have an important role to play in our hometown as a key employer, as a key partner. So we've made some real investments or some real commitments over the last couple of weeks in Louisville, commitments on investing in the physical space with the Urban League to develop and create healthier sort of physical places for exercise, healthy lifestyles. We're investing heavily in a variety of different social determinants, but ultimately the driver here is going to be getting closer to the community and working from the community back, fundamentally understanding what's happening within communities that we can address, that we can support, and doing so in deep partnership with local and state governments. So I feel like this is a time where we're all going to learn. We all have to learn together. We certainly don't believe we know the answers. It's great that Shantanu and NQF have given us a roadmap. It's great that we have incredible partners like the AMA to work with. But this is the time where we're really going to roll up our sleeves and learn as we make these big investments and try to make a difference.
Great. Thank you so much for that. Sounds like you've got some really awesome people working on the bold goal. So you're lucky.
That's what I hear. That's what people say.
Dr.
those who
Kelly
don't-
Pryor, would you like to give some comments as well, please?
Andrew, position leader on that.
Well, I'm glad to join this panel. Thank you all for having me, and the foundation, the Humana Foundation. You know, we see ourselves as a cousin of the Bold Goal team. So we are able to work alongside you all as the 501c3 partner of Humana. And so what we do in communities, I'm really just excited to hear, you know, your words, Dr. Schrank, in terms of not knowing everything and working alongside communities. So when the Humana Foundation made a commitment to health equity, it's been about 2 years now that we've been in a new strategy of really digging deep and funding health equity in communities. And to do that, we need to do that in co-creation. We really see I've been in this work of health equity for a long time now, and one of the strategies that we've employed in the different places that I've worked around the country, and just the going statement around health equity, is that those who are closest to the issues have the solutions to the problems that we need to solve. And so how do we really flip our understanding of what is a problem and what is a solution and who has the answer to that through co-creation? And so that's what we're doing at the Humana Foundation, and really focusing in on health equity, focusing in on how do we disaggregate data, how do we get really specific about social determinants of health that we're interested in, of which we have 4 main areas that we're focusing on, which are social connectedness, food security, financial asset security, and post-secondary success and employment. But we know that at the foundation of all of that in a community is, as Dr. Harris was talking about, these are the social determinants of equity. These are the structural elements. How did these social determinants become what we're seeing in our community? What were the policies, the procedures, the practices that allowed the isms in our community to flourish in the way to where some do not have the same social needs as others, and those disparities between their needs, or those inequities between their needs, are creating the life outcomes and the life expectancy that we see in community. So when we're talking about the funding that we give through the Humana Foundation, it really is a life or death situation. And it is not only for those communities in which we are seeing the lower life expectancy or the less health outcomes, but we know from public health data that this is actually impacting the health of our entire communities. And so we oftentimes, I think what this pandemic has disrupted for us is this notion that it is an us and them mentality. It is those who have poor health and those who are flourishing in communities without understanding of how that has happened. And what we're seeing, and what we see through the social distancing even, is that we are all going to be impacted if we do not work in the areas in which we need it the most. And so between our 2 pandemics that are happening right now, between COVID-19 and racism, I think we're really starting to change our value system on how do we fund in community, how do we co-create deeper in community, and how do we challenge that dynamic of what does it mean to have power based off of the economic or financial assets that we are able to employ or deploy to the communities that we're able to serve. And right now we're in 8 communities through our strategic community investments in the Humana Foundation, but we also are through our disaster philanthropy, and particularly as a result of COVID-19, have really expanded our footprint throughout the nation in terms of looking at how are these, particularly inequities as we're seeing as a result of systemic racism, how are those impacting other communities that we were not necessarily serving alongside the Bold Goal prior to this moment. So it has really challenged us in new ways. I'm excited for the path forward and really our vision around anti-racism.
Fantastic. Thank you so much, Dr. Kelly Pryor, for those comments. And actually, it's a great segue into our questions. I want to start with something that both you and Dr. Harris mentioned, the idea of a difference between social determinants of health and the structural determinants of health. So my first question to put out to you is, how does systemic racism manifest in healthcare? I might start with you, Dr. Agarwal.
Yeah, thank you. I have to say, I really agree with the comments that the other panelists made and the vision that they put forward. I think we can all absolutely agree that there are structural elements of our society that absolutely affect, populations in terms of their health outcomes, and specifically people of color, populations of color, and even more specifically African Americans. I think that is demonstrated time and again in the data. We can see over the last 20 years, essentially, of the modern quality movement, a march towards improvement among a number of different quality measures. And yet there's demonstrated data to show that, again, these populations, racial and ethnic minorities, particularly African Americans and Latinos, are lagging behind that overall general improvement in quality and quality outcomes. We talk about these structural features and elements, I think, in a variety of ways. So social determinants, I think, has a lot of our attention and focus right now. That's absolutely great. I do wonder, though, if we spend enough time talking about care delivery itself and how that contributes to these disparities. So importantly, I think Dr. Harris mentioned unconscious bias at the top of her comments. I think we've got to spend a lot more time talking about implicit or unconscious bias. That is absolutely, in my view, another manifestation of these broader historical and structural issues. I think we've got to recognize that delivery system workers, that everyone that's sort of involved in healthcare, we are all outcomes of this historical and social milieu. We have the same prejudices, the same biases, the same perceptions that other non-clinical, citizens, peers have. And again, the data have been very clear that there are disparities and discrepancies, not just in the outcomes that are achieved by population, but how people and individuals and populations are treated, how they're diagnosed, how their chronic and acute issues are managed, even issues like pain, how they are addressed. I think there's a great deal of comfort looking outside of the healthcare system, pointing at the bigger social issues and putting our finger on it and saying, these are problematic. These have to be dealt with, whether by us inside healthcare or by the social safety net. But there's far less comfort in looking inside and saying, how are we contributing to these problems? I think we've got to spend a lot of time in doing that because it's not clear to me that everything that we are doing in healthcare is actually contributing to the solution. I think we are becoming, in some ways, additive to the challenges that these individuals and populations are facing.
Andrew, I wonder, as I'll just say this quickly, language is very important, and I think all of us need to be on a journey to be more clear about the language that we use. And so sometimes we get too caught up in, is it a structural determinant of health? Is it a social determinant of health? And I even wonder if we should not even use the term social determinants of health, not because they don't exist, but I think there is a valence to social determinants of health. And some folks don't even think that those of us in the healthcare community, many of you probably saw this debate last year, should even care about the social determinants of health. And so I actually have begun to talk about the determinants of health. And there are so many determinants of health, and they are policy determinants. They are structural, baked in the cake. I will say redlining of years ago, where there was discriminatory housing policies and African Americans could not get a mortgage in certain areas, and then they were driven to particular areas, and lower opportunities for education and employment, which led to lower tax base. And so I just think we should really have a broader discussion about all of the determinants of health, and then certainly decide and commit to all of nation approach, if you will, to address some of those issues. I will just take a brief moment of personal privilege and glad to see Humana working in Louisville. And notice I did say Louisville because I have been going to Louisville since I was 6 months old. 3 of my father's siblings moved to Louisville from West Virginia, which is where I'm from. And that's where we went. We went to Louisville every year on summer vacation. And we did live on the west side off of Muhammad Ali Boulevard and West Kentucky. And so I am intimately familiar with that area of Louisville that over the years has changed. I'm not going to say how old I am, but many, many years it's even changed in those years. So I'm glad to see that. But I think that just drives home the importance of community involvement and engagement. And I'll say one more thing about language. Even the title of our webinar today is Population Health. And I think that as we move forward, we also need to be clear about what population, we are thinking about. I'm a former county health director, and certainly at one point I could be talking about the county on a population level. But I think as we navigate through this current system, we will have to be careful because we'll have to, I believe, resist the urge for one-size-fits-all solutions and to talk about the population without really talking about the needs of different groups in the population. I mean, that's what we're doing today, right? And so I think as we move through, we'll have to be clear about which population we're talking about and the measures we will have to make, and I know this has been the work, we'll have to make sure those measures are meaningful. I appreciate the work, Dr. Agarwal, because we sometimes get in a habit of checkbox measures, right? And these are checkbox measures, and we might be meeting the checkbox, but really not making a difference in the community. So I think as we talk about language and definitions, we'll have to make sure that we have the same goals in mind as to how we really want to get to improve patient and community and population outcomes.
I think that's exactly right. I would agree with, in terms of thinking about when we're talking about a social determinant of health, I think even in coming into a role around health equity, oftentimes people will want to pigeonhole it of let's talk about obesity, let's talk about heart disease, let's talk about the health outcome, instead of actually talking about, well, health is really the entire holistic being of a person and their community. And so when Dr. Harris is talking about these policies that actually codified where and how someone could live, and then over generations and generations, we're seeing outcomes as it relates to heart disease and diabetes as a result of one's housing practice. We can't disaggregate housing from a conversation around health just because we want to talk about the disease state or the disease outcome. So I think it is really important that we hone in on our language, and that we really, especially in this time of pivoting towards talking about equity in a more critical way, that we have a vital conversation around really what is the power dynamic in a community, and how has that power dynamic been structured by the economics of that place. When we're talking about environmental quality in Louisville, we cannot separate that from most of the corporations or most of the environmental pollutants have been placed in a particular area of town. And so when we see these high rates of cancer, that is not a personal behavior. That is really based off of the environmental structures around, as well as what laws have allowed that to persist in terms of what can go into a particular environment and subsequently into a particular person. So I think it's important that we have a conversation about language, and also think about how healthcare is disaggregating data in a way that is going to be useful. It is not, we cannot take a monolithic view of African Americans or Black populations in the US and have an understanding of this is what is happening. We really need to intersect that data, not only by where someone might live, but income. And until we're really able to have a conversation about intersectionality, we are not going to fully be able to address the issues that we do have as it relates to systemic racism.
So Dr. Kelly Pryor, that's a fantastic segue into where I was going to go next. So I love the conversation about the difference between structural and social determinants. And then we also have a term, health-related social needs. And social needs tend to be more immediate. It's food insecure today. versus a more structural determinant of your health. So you talked a little bit about this, but how do we get more explicit in how we measure disparities and inequities? You know, is it a matter of first defining terms and definitions? And then I just feel like we have an incomplete data set. So how do we get the data that then informs the strategy?
Right. I think, there's a lot of frustration by communities that feel like there is enough data. You know what the problem is. Now let's get to answering it. So there is that paradox or that challenge of, do we have enough data, and is the data actually complete, versus communities are tired of being studied and they're tired of not having the actual solutions. So a part of that, the way in which I meet that paradox is, okay, what data points are we not discovering? Even thinking about our census right now and our understanding about gender and sexuality. Do we have a really good understanding of what this moment means when we're talking about racism? How does that intersect with trans individuals, trans women and trans men who are in communities who are also people of color, who are also I think the life expectancy for a trans woman of color is under 35 years old, but we also need to have a conversation about life expectancy differences when we're looking here in our hometown in Louisville, that you can have a 12.6-year life expectancy gap based off of where you live in a particular zip code, or based off of your racial background. And that could be you're living in the highest zip code in terms of income, but because of that stress, the racism that one is experiencing, and we see that with more infant mortality as well as maternal mortality rates, we see that concept of John Henryism that's talked about by Sherman James, of constantly trying to push against a system of racism, and how that has a weathering effect or a toll on someone's body. So I think in terms of dissecting our data or disaggregating our data, we need to have a really deep and holistic conversation with the individual and the individual communities in which we're working with, to understand the nuances around these social identities. I say race does not matter, right? Race is not an actual biological determinant of how my health will be, but in terms of how that race is perceived in society and how that's actually functioning in the power dynamics and the power systems in which I have to navigate, that is going to have an impact on my health. And so getting beyond just how are we talking about the particular identities of a person, we need to talk about the isms and the power structures in our society that are causing those particular social identities to interact with someone's full life outcomes.
And I'll just say one more thing about data. I think we should, and maybe this is happening, but we should go into the community and say, look, here are the data points that we are collecting. What would be a meaningful data point that you would want us to collect? What is improving your health mean? What does improving your health mean to you? Now, granted, these may not be very easy data points to collect, but I think that's where we need to start. Because we can collect data and it can just be data for data's sake. And so we need to figure this all out. And it's not easy, but I think we need to start with the community and say, here's what we're collecting. What's meaningful to you? How will you know if 5 years from now we are doing better? What will be the metric for that? We can start there and weave that into what we already have. But I think it's so important to have that conversation with those that are most impacted. Again, I'll just make up something off the top of my head. For one community, they may say, well, their health will be improved when they have well-lit sidewalks. Now, I get that, and so perhaps we should be measuring whether or not a community has well-lit sidewalks from, 5 years from now. So I use that as an example. It might be a hyperbole, but I think we need to start thinking innovatively, even about the data that we collect. And Brandy said something. I think that we have to be careful because there's that trust and African Americans and other communities of color. But I believe particularly African Americans, believe that don't you have enough data to identify the problem? Can we hear what you're planning on doing about the data that you do have? So it is a paradox, and I think it will just require us to continue to have these conversations around that issue, but include folks who are involved and engaged at the decision-making table, at the power table.
Yeah, maybe I'd love to build a little bit on both what Dr. Pryor and Harris said around measurement. So it's a really good point that you can't fix something that you're not measuring, and it is I think Dr. Harris's perspective that if you're not getting feedback from the sort of folks you're trying to help, you're probably not going to be focusing on the right stuff. But it's interesting when you think about sort of what we're measuring in terms of what's process, what's outcome, and how do we think about our role as a payer. So from a payer's perspective, we have a whole host of measures that we apply to think about disparities and to think about the sort of the health and the experience of our membership. And they range from, sort of some of the key drivers of social needs, health-related social needs. They include the processes of care, the HEDIS kinds of measures, the measures that Shantanu's organization often develops around how to sort of characterize the quality of care that's being delivered. There are outcomes that we're trying to produce. So, specific health outcomes, the frequency that patients, our members, have heart attacks or strokes or die, or those intermediate outcomes that impact those, like that characterize the behaviors that impact those outcomes. So adherence to medications or treatment plans. And then there's the experience with care, the satisfaction with the interaction with the provider, the interaction with us as a payer, the care managers, the satisfaction with the process, with their experience with the healthcare system. Now, we have implicit weights that we put on those variables based on what we think makes sense. But Dr. Harris is exactly right. If we're gonna really align measurement and incentives with the outcomes we're trying to produce, we've got to get into communities and say, well, what's the most important for you? And how do we create ultimately we want to create composite measures that really weight the measurement characteristics that are most valuable. One other thing that I think is really important for us just to bring up briefly in this discussion is increasingly, whether you're a payer, whether you're a provider, anybody that's focused on improving the health of populations is leveraging data analytics at large scale to risk stratify, to identify who needs proactive outreach, to deliver target interventions, outreach, and clinical solutions to patients in order to optimize their health outcomes. All of those algorithms are based on underlying data that was collected in the setting of all of these structurally racist, structural prejudice that's happening in our society today. And it's essential that as we rely more heavily on our AI algorithms and on data analytics to guide our care and to guide the type and the channel that we outreach to our members or our patients, that we're paying extra special attention, really focusing on the QA there, the quality assurance, to make sure that we are not accentuating or propagating disparities that are underlying in the data on which we're basing those algorithms. Right. So ultimately, we're sort of at the, while we're focusing, I think, heavily in this discussion on measurement and on data, it's well-founded, and that's at the core of our ability to make a difference.
All right, I got to get in there a little bit since we're talking measures. It's very important, obviously. I agree with the viewpoints that have been expressed. Just two additional points. First, there is a lot of data in healthcare, clearly, and yet there's such a maldistribution of that data that I think that becomes problematic in and of itself. And the level of granularity that's really available in the data to drill down to anything but the most generic population levels is still extremely limited. We see that in our own work on measurement as we try to understand the impact of social risk. The granularity, the complexity in the data sources are constrained enough today that we can't get to the level of measure sophistication that I think all of us on this panel and far beyond are trying to drive towards. It's clear to me that we can make better use of existing measures in the right sort of data context and setting in order to be able to disaggregate measures, understand the impact, or understand how outcomes, even processes, look different based on different populations. That activity in and of itself is extremely important. In my organization, we often, we will often, retain endorsement of a measure if it's clear that even though at the overall outcome levels, there's good performance in the healthcare system, if once you disaggregate it and you can see that at stratification, there are populations that are still not at that high level of performance, we will retain the measure because that measure still has applicability. So there clearly can be better use of measures that exist today. But to Will's point, we need a whole new set of measures to be developed that really are addressing disparities, social determinants, whatever the right terminology will be as we move forward, that are focused on that and that get baked into the healthcare system just as prominently as more clinically focused measures. And the final point, measurement for improvement is absolutely critical. I think we all have to ask the question how measures should intersect with payment policy, because we certainly have enough dollars in the healthcare system to start to impact these very determinative issues. And I think measurement needs to light the way on that.
Thanks for that. I wish we had hours to talk about data and analytics and measures because it's such an important topic. But before we run out of time, I do want to get on to a couple of other topics. We've talked about these issues being systemic and structural. So from a proactive and a positive standpoint, how can we drive cross-sector collaboration to solve for these issues? So thinking about payers, providers, other types of organizations, how can we work together to solve those? That can be alternative payment models. It can be, programmatic innovation. But how do you all think about how different sectors can work together to solve these issues? Dr. Schrank, would you like to start us off?
I would love to take a first cut at this. So I'm glad you sort of highlighted alternative payment models, because that's one way that we can, at the outset, align in everyone's incentives around a set of goals and priorities of delivering better care and more equitable care and producing more equitable outcomes, and making sure that we are all entirely aligned around what we're measuring and how we're rewarding, creating incentives that really are organized to deliver the outcomes we want to produce. It is awesome to think about what we can do when payers and providers are working together, when we are focused on, when we say that the rewards are going to be aligned with outcomes that produce less disparities, more equity, better health, higher value, more upstream care. And the advantage of alternative payment is as soon as the provider has, as a payer, when payers take risk, which we generally do, we have this unique ability where we are paid a certain amount of money to manage the health of a population. And we are in a unique position that we can reallocate some of those healthcare dollars to go upstream and to invest in the key barriers to achieving better health. And by doing so, there's a bit, and in an environment where it's very hard to find additional dollars to pay for social services, we're in a unique position as payers to be able to reallocate healthcare dollars to social services and create a business context for doing so. As soon as we start sharing that with providers, and payers and providers are working together to really think about where to invest healthcare dollars to optimize health, how to think about preventing rather than treating, to really move the healthcare dollar upstream to produce the healthiest population, the opportunities are quite extraordinary. And we're seeing that, overwhelmingly, some of these differences in the COVID outbreak during the pandemic, where our partners, our providers that are taking risk and are prepaid, have been able to fundamentally change the way they practice to address a remarkable new set of a remarkable amount of uncertainty in the setting of the pandemic. And they've been able to fundamentally change the way they use technology, fundamentally the way they change the way they see patients using telehealth, fundamentally change the location in which they see patients increasingly in the home. Think about that same kind of flexibility being applied to addressing disparities and explicit financial rewards aligned to reducing those disparities. I am certain that in that setting, payers and providers with the assets and the resources, and as Shantanu highlighted, there's enough healthcare dollars out there to be able to sort of reallocate and ultimately solve a lot of these problems. We are in a position, I think, to really take on some of these really sort of hefty issues in a much more coordinated and complete way.
So I think I just heard Dr. Schrank say data sharing and getting people in the room who are participants in new payment models. And certainly, physicians are happy to hear that. One or two is not enough and 1,000 is too many, right? But we've got to think of, again, get out of this one size fits all model. And again, bring in physicians and other members of the healthcare team in the beginning. I know you all know how physicians feel about electronic health records. And one of the reasons why we didn't get to where we wanted to be, the promise of electronic health records, is because physicians weren't at the table in the beginning. And certainly even the goal of them in the beginning was more about payment and billing and not about care. So I think the important thing to do is, again, we have to figure out data sharing, and we have to get physicians and other members of the healthcare team in the room as we are developing these alternative payment models and really think about what really works, again, to get the goals that we want to get to. So I'm happy to hear that. Of course, we're not going to solve that on this, but I think, if we just think about one or two payment models, that won't be enough, and physicians need to be at the table and share that data and have that data drive decisions. But where there are data gaps, or you need to be collecting something else, which was the previous conversation, we need to have that conversation. Dr. Agarwal, you gave me a bit, and you won't be surprised to hear me say this as a physician, because here's the worry, and I heard you say, and I know you're really working on this. And when you talk about retaining a measure, absolutely. But at some point, we have to, I know I think I won't even say the name, because the decluttering model is you only bring one thing into the house if you take something out. So I can't do that to declutter my own house. But I think as we think about measures, we should be really careful, because if we are just piling measures on, right, if these are important and they still have some value, so we're going to retain, but we're going to add 10 more, just candidly, that's untenable. So we really need to figure out a way, and I know you know this, and we're looking at this, or 2,000 measures, and I'm totally looking at this from the physician perspective, who might have 5 different payers, right, that I have to report measures on. And it gets to be candidly too much, and again, we get lost in measures, and we don't get the patient outcomes. So, I know that you really are interested in making sure we get to good measures, but I think we do have to have some tough conversations about, at some point, we need to pare down and find, and they won't be the same. As a psychiatrist, maybe my 10 measures will be different than the oncologist's 10 measures, and I might have and of course, all psychiatrists are not monolith. And as a community psychiatrist who only treats children in the foster care system, my 5 measures might be different than the psychiatrist who treats, in a wealthy, community. And so I think, again, it does get complicated, but I think we need to at least have some of these concepts in mind as we move forward. And I'll say one more thing about, again, having folks at the beginning and AI and all of this, because I think we have seen how AI has been discriminatory. It's been discriminatory as to the facial recognition software, and now I can't remember the example, but I think a healthcare team or organization found that African Americans were getting less care based on an algorithm. So we really have to be very careful. Of course, there's promise and peril in technology, but we really need to make sure we have the people around the table who can bring these issues up at the beginning, so that we don't get into trouble and we don't further exacerbate health inequities.
Thanks, Dr. Harris. And just for the sake of time, I'm going to ask each of you maybe to give just sort of 1 minute in closing comments, but to comment on what each of your organizations can do to help solve some of these structural racial inequities. And I think you comment either from the perspective of even within your own 4 walls. I mean, we think about things like cultural competency training and affinity groups and development type programs, and then also projecting outward your externally facing strategies to address these issues. I know it's a lot to cover in a minute, but I might, Dr. Agarwal, I'll start with you.
Yeah, thank you. Again, rich dialogue. I think first, obviously, we are a measurement organization. That is, our central role. I take Patrice's comments, obviously, to heart. There's a real tension there, right, in terms of being able to cull measures down to manageable sets, and yet recognizing that we don't have fundamentally as an ecosystem measures in areas where we desperately want them, right? We don't have great food security measures today. We do not have great maternal mortality measures today. Both of those issues, plus 10 more, are very salient for these various populations, various groups that we are extremely concerned about. And so this question of how many is enough is presented to me basically every day, and I struggle with it. Part of the measurement enterprise's issues, I think, are due to other structural issues like interoperability of data and sharing, like how well claim systems and EHRs and registries work with each other. Those are structural limitations that I think if we could address, we could have the measures that we want, all highly vetted, all very scientific, to make the progress that we want to see. So in addition to obviously thinking a lot about measures, which is our focus, I think about a few more things. First, I do think it's important to keep line of sight to the biases and behaviors inside healthcare that are exacerbating social issues. I can't say enough about that. I think we have to work on it from a measurement standpoint, from a survey standpoint, from a training standpoint, to kind of remove those behaviors from delivery. Second, I think about this certainly as an organization. What is the community role of our organizations? We are all employers, some on this panel much larger than others, yet we have a role to play as employers. How can we contribute to education and training so that people in our communities can learn new skills, get ahead, be part of our organizations, provide, I think, real value to our organizations, and we can help to address in our own way the various social challenges that we've talked about today. And the last thing I'll say, only because it's an important healthcare issue, population-based payment, I think, needs to occur. It's not just about APMs generically. I'm not sure, for example, how a bundled payment would really help to move the needle on the issues that we're talking about. I think we've got to start molding payment around populations and groups so that we have the right incentive structure in place and a long enough time frame to make some real change and progress. I'm happy to couple those with good measures so that we can get the work done that we need to get done.
That's great. Thank you so much. Dr. Kelly Pryor, would you like to go next?
Sure. This has been such a rich conversation, and I think it's just reinforcing this moment around us really identifying what our value system is and how do we put health in that equation. Is health a right that communities should have as a result of being a living organism, on this planet. So I think that is really what we're grappling with, and how we get down to doing that is, yes, being multi-sectored in all that we do. Our primary agency in community is funding. It is granting and investing in community organizations. But we know that that is an inside-outside work that has to happen. The inside work is for us to challenge those power dynamics that we have had as funding institutions. Challenge why do we give minimums instead of maximums in community? Why do we put out RFPs? All of those questions that the system, the way in which it was set up from the very beginning, that is a structural bias. That is structural. When we're talking about structural racism, when we see and we center a particular group of people, particularly in this country, if we center whiteness over any other, then that then becomes the norm in the center. And so us really kind of reframing and rethinking, why do we do the work that we do, and how do we do it with community members who are not only seated at the table, but who in some ways invite us to the table instead of us coming to communities and inviting them to the table? How do we reframe and reshape our conversations? I think, we really need to have a conversation about ownership. And so when we're talking about healthcare, how is there ownership of data in community? When we're talking about even how we do the research from a funding perspective, how do we say this is co-ownership, or we are coming in and we would like to learn alongside you there. So that is really where I think a lot of our inside-outside work happens with our Community Partners program in Louisville. We have had really intentional power analysis, working with outside organizations who've done that in public health organizations and communities as well, human impact partners. And we are knowing that we're getting closer to it every day, and we haven't achieved it yet. But I think getting to that place where you're saying, I need the answer, I need the objective measure, challenging that and saying, who is determining this to be objective, and or why, and the time frame in which we put on the solutions that we need to get to. How are those solutions determined by a structure that is not conducive to community partnership? So that is really, I think, one of the last things that I really want to end with. We were having the conversation about data, and Ruha Benjamin in her work on Jim Code really talks a lot about the way that which the AI and the data is constructed through the system, the soil of our community, that we really need to be challenging right now, is that idea that it has all been, it has worked intentionally and it has worked well in terms of creating a power system in our country. And so how do we dismantle that and say we're willing and we're imaginative and we're excited for another world that is possible?
That's great. Thank you very much. Dr. Harris.
Yeah, so I think the key is to put the mission and value statements of our organization, and any statements we are all making, many corporations, many organizations, institutions are making about racism and addressing health inequities. We have to bring those words on paper or on social media to life. And that requires looking not only externally, but also looking internally. And I can tell you at the AMA, we are looking internally as we seek to provide guidance and work with partners externally. For many years, the AMA did not allow African-American physicians to join our organization. So African-American physicians created a separate organization. In 2008, the AMA apologized for that. Now, certainly that was necessary, but not sufficient. And I just want to just focus in on the actions. And so we have to, again, bring our words to life. And so at the AMA, we are looking internally. We are looking at who's on our teams, who's in leadership. We are doing just did a pulse survey of our employees, particularly now, as they are experiencing this particular time in history. So looking internally, I already talked about a few of the things we're doing externally. We are also working in our Accelerating Change in Medical Education program to make sure we have some medical schools in a grant program that are looking at cultural competency, looking at how we train the next generation of physicians. We are looking at the diversity of the physician workforce, pipeline programs, and making sure we are supporting those programs as well. And of course, our initiatives around diabetes and hypertension. So it requires, as we move forward, a focus, look inwardly, and also a look externally.
Thank you. And Dr. Schrank, the final word to you.
All right. Well, what a rich conversation. And again, a big, big thank you to my old friend Shantanu and Dr. Harris for your participation, and really just proud to work with you, Dr. Pryor. Really great comments. I'll just be quick because I know we're up against time here. But two things. One is to build on what Shantanu said. Population payments, advance payments, this notion that providers and payers together are thinking about managing populations is at the core of our getting from where we are today, which has produced not the outcomes we're trying to produce, to rapidly transforming to aligning around a vision of more equitable and higher quality care that delivers better outcomes and lower costs. And I think that this is, if there's ever been a transformative moment where we can really accelerate that movement to real population payment or prepayment, I think this is it. Secondly, I would just say for us, it's all about transparency. We have to have the conversation. We have to talk about the hard thing. We can't be afraid to talk about race. We can't be afraid to talk about what we have done wrong for many years. We can't be afraid. We can't walk away from our past or our present. We have to open our eyes. We have to talk to each other. We have to listen to each other. It'll impact the measures. It'll impact how we create new interventions and new approaches. It'll impact how we structure our payment. It can impact how we do everything about how we deliver healthcare. It will impact how we care for people. It will impact the equity of health in the U.S. And I think it's only with real open dialogue, conversation, transparency that we're going to be able to take some ground. So thank you.
Well, thank you for that. Thank you to the panelists. Thank you to everyone who listened. Thank you to the National Press Club for hosting us. It's been a fantastic event, and I appreciate everyone who participated. So everyone have a great day.
Thank you.
Thank you. You too.